Hello guys, this is Indian Medico, and in this video we'll see a review of transfusion medicine. First, let us discuss Landsteiner rule. It is useful in ABO blood groups. The rule states that if you lack the RBC antigen, you make the antibody to it. For example, let us see type A blood group. In this case, there will be type A antigen on RBC and anti-B antibodies in plasma. Now let us see about universal recipient. Type AB is the universal recipient because this type has no anti-A or anti-B antibodies in plasma. Now let us see about universal donor. Type O is universal donor because it has no A or B antigen in RBC. RH positive indicates presence of D antigen on the person's RBCs. What is RH immune globulin? It is IgG anti-D antibodies in a purified preparation. They are given to RH negative mothers in pregnancy to prevent hemolytic disease of newborn. Now let us see this picture. This picture shows type A blood group. Type A blood group has antigen A on RBCs and anti-B antibodies on plasma. Type B blood group has antigen B on RBC and anti-A antibodies in plasma. Type AB has both antigens A and B in RBC and neither anti-A nor anti-B antibodies in plasma. This is known as universal recipient. Now let us see about type O. Type O has neither antigen A nor B on RBC and it has both anti-A and anti-B antibodies. This is known as universal donor. This is type O. Now let us see about other clinically significant RBC antigens. These include KID, which can cause severe acute hemolytic transfusion reaction if mismatch is there, Duffy and Kell. Now the donated blood should undergo standard tests for anti-HIV1 and HIV2 antibodies. Also, we have to do HIV1 P24 antigen by ELISA and HIV nucleic acid testing to detect very early infection. Citrate is the anticoagulant used in blood components. The mechanism of action of citrate is it binds calcium ions, making them unavailable to be used as cofactors in coagulation cascade. Now let us see about blood components for transfusion. The various components available for transfusion are red blood cells, fresh frozen plasma, platelets and cryoprecipitate. Now let us see about each of them in detail. Packed red blood cells or PRBC, they contain no platelets or clotting factors. Whole blood, it contains red blood cells, white blood cells, plasma and platelets. They can be used for acute heavy bleed. Fresh frozen plasma or FFP can be used to replace clotting factors. Cryoprecipitate, it contains von Willebrand factor, factors 8 and 13 and fibrinogen. It is used in hemophilia A, fibrinogen deficiency and von Willebrand disease. Platelets can be used to replace low platelets. This picture shows the various blood components. First, we have to do education, recruitment, selection and donation. Then we have to test the blood for HIV, hepatitis B, hepatitis C, human T-cell leukemic virus, syphilis, ABO blood group and RH antigen. Then we have to process the blood into blood components. We have to use filter to remove leukocytes. We'll get packed red cells, pooled platelets and fresh frozen plasma. PRBCs should be stored at 4 degrees Celsius and they can be stored for around 35 days. Pooled platelets have to be stored at 22 degrees Celsius and they can be used for up to 5 days. Fresh frozen plasma should be stored at minus 25 degrees Celsius and they can be used for up to 36 months. We have to confirm the compatibility and then transfuse them to a patient. Now let us see about type and cross. It is essential before blood transfusion. The patient's RBCs are cross-matched to available donor blood for transfusion. Patient's serum is checked for preformed antibodies to the RBCs of the donor. Type and screen is also done in blood bank. In this case, the patient's blood type and RH antigen are determined and the donor's blood is screened for common antibodies. Now let us see about major cross match. In this case, the patient's serum is mixed with donor RBC and we incubate, then we centrifuge. After adding 2 drops of AHG, if there is no agglutination, it is compatible. If there is agglutination, it is incompatible. This has to be done before transfusion. It is important to remember that an average adult has 8 to 10 units of whole blood in his body. What are the indications for packed red blood cell transfusion? Hemoglobin less than 8 gram per deciliter. In case of coronary artery disease, if the hemoglobin is less than 10 gram per deciliter, we have to give packed red blood cell transfusion. It is important to remember that 1 unit of packed red blood cells can raise the hemoglobin by 1 gram per deciliter and the hematocrit by 3%. If the patient has history of febrile reactions to blood products or if he is a chronically transfused patient, we have to give leukocyte reduced RBCs since they decrease the risk of human leukocyte antigen, that is HLA autoimmunization, and the risk of transfusion reactions. For the purpose of intravascular volume expansion, we can use albumin, crystalloid and colloid and not FFP. Now let us see about platelet transfusion. Prophylactic platelet transfusion can be given when the platelet count is less than 10,000 cells per millimeter cube. Prior to surgery, we can give platelet transfusion if the platelet count is less than 50,000 cells per millimeter cube. Platelets can also be given to aid coagulation in actively bleeding patients. The dose of platelets is 1 unit in adults and 10 milliliter per kilogram in pediatrics. Now let us see about apheresis platelets or single donor platelets. They are platelets collected from a single donor during an apheresis procedure. First of all, what is apheresis? Apheresis is the process of separating the cellular and soluble components of blood using a machine. It is important to remember that platelets are not indicated in patients with thrombotic thrombocytopenic purpura, idiopathic thrombocytopenic purpura, and disseminated intravascular coagulation. In these cases, platelet transfusion will only perpetuate the problem. However, even in these cases, we can transfuse platelets if the patient is actively bleeding. Now let us see about acute rejection. It is also known as acute hemolytic transfusion reaction. In this case, the patient received RBCs with an antigen to which he had previously formed alloantibodies such as ABO antigens or KID antigen. The most common cause of acute rejection is clerical error leading to ABO incompatibility. The clinical features of acute rejection are fever, chills, tachycardia, shock, and acute renal failure. Now let us see about the treatment of acute rejection. We have to stop the transfusion. We have to give intravenous fluids, that is, we have to give intravenous fluid resuscitation. The patient should have good urine output. If urine output is not sufficient, furosemide, that is, Lasix, can be administered. Now let us see about other side effects of blood transfusion. The most common metabolic side effect of massive blood transfusion is alkalosis due to citrate anticoagulant converting to bicarbonate in the liver. Febrile non-hemolytic transfusion reaction depends on the number of leukocytes present in the blood component. Now let us see about allergic or anaphylactic reactions. They can occur even with FFP transfusion. Patient has IgE antibodies against plasma proteins in the transfused blood. It is most common in patients who are IgA deficient and have preformed IgA antibodies. It can be prevented by using washed RBCs and platelets, or we have to use plasma from other IgA deficient patients. in patients who are IgA deficient. Now let us see about transfusion related acute lung injury. In this case, donors' anti-leukocyte antibodies react with the recipient's leukocytes. Clinical features include pulmonary edema, fever, tachypnea, and cyanosis. It is important to remember that blood transfusion recipients are at greatest risk for bacterial contamination more than HIV or hepatitis. This picture shows the various transfusion reactions. In case of normal transfusions, there will be small variations in vital signs. When there is hives or itching, it indicates mild allergic reaction. When there is fever or chills, it indicates febrile non-hemolytic reaction or acute hemolytic reaction or bacterial contamination. When there is hypotension, we have to suspect acute hemolytic reaction or bacterial contamination. It can also be due to anaphylactic reaction or transfusion related acute lung injury. Dyspnea can be there in anaphylactic reaction or transfusion related acute lung injury or in case of volume overload, that is transfusion associated circulatory overload. Remember, when there is a transfusion, ionized calcium in the blood decreases because of citrate which binds calcium. The risk of contracting hepatitis B from blood transfusion is 1 in 200,000 units of blood. The risk of contracting hepatitis C is 1 in 2 million units of blood. It is the same for HIV. It is also important to remember that packed red blood cells can be stored for 6 weeks. Now let us see about direct antiglobulin test and indirect antiglobulin test. It is a direct antiglobulin test is abbreviated as DAT. It is also known as direct Coombs test. It detects the presence of antibodies coating the patient's RBC surface in vivo. First, the patient's RBCs are washed. That is, we have to remove the patient's plasma and then incubated with Coombs reagent, which is anti-human globulin. If agglutination of the RBCs occurs, the test is positive. Positive test indicates antibodies on the surface of the patient's RBCs were present and bound the RBCs reagent in order to agglutinate. Now let us see about indirect antiglobulin test, that is IAT or indirect Coombs test. It detects RBC antibodies in the patient's serum, that is in vitro binding of IgG. The patient's serum is extracted in this case, that is we remove the RBCs and incubated with standard RBCs that have known antigenicity, and then the Coombs reagent is added. If agglutination occurs, the test is positive. A positive test indicates presence of antibodies in the patient's serum binding to an antigen on the standard RBCs and then binding Coombs reagent in order to agglutinate. Now, if you notice, there are quite a few differences between direct and indirect Coombs test. For example, direct Coombs test detect antibodies on the patient's RBCs, whereas indirect detects antibodies in the patient's serum. In direct Coombs test, patient's RBCs are washed, that is we remove the patient's plasma, whereas in case of indirect, we remove the patient's RBCs. This picture explains both direct and indirect Coombs test. Blood sample from a patient with immune mediated hemolytic anemia is taken, that is it will have antibodies on the RBC surface. We take the RBCs, the patient's RBCs are incubated with anti-human antibodies, that is Coombs reagent. Then if the test is positive, the RBCs agglutinate. In this case, the test will be positive because it is a case of immune mediated hemolytic anemia. Now let us see about indirect Coombs test. Recipient's serum is obtained. It contains antibodies. Now the donor's blood sample is added to the tube with serum. The recipient immunoglobulins that target the donor's red blood cells form antigen-antibody complexes. The anti-human immunoglobulins, that is Coombs antibodies, are added to the solution. Then there will be agglutination. Now let us see about coagulation. First, let us see about normal coagulation. First, there will be damage to endothelium. Then there will be platelet binding and aggregation. Then coagulation factors help lay down fibrin to form and stabilize a clot. Now let us see about partial thromboplastin time and prothrombin time. PTT tests the intrinsic coagulation pathway, whereas PT tests the extrinsic coagulation pathway. PT is measured in International Normalized Ratio or INR. Now let us see about the use of fresh frozen plasma in patients on warfarin. It reverses anticoagulation quickly, but it is difficult to get the patient back to therapeutic INR. Vitamin K has a much slower action than FFP in treatment of warfarin toxicity. Now let us see about therapeutic INR in various conditions. For atrial fibrillation, the therapeutic INR is between 2 to 3. For mechanical prosthetic heart valve, the therapeutic INR is between 2.5 to 3.5. For deep venous thrombosis, the therapeutic INR is between 2 to 3. If there is a recent thromboembolic event with therapeutic INR, the therapeutic INR changes to 2.5 to 3.5. If you have any suggestions, please let me know in the comment section. For more such videos, please check out my playlists. If you like my videos, kindly subscribe. Your subscription will encourage me to make more videos. Thank you.